given the issue that we talked about, given some of the disruption and the opportunity with these new technologies, if you had incremental capital to deploy in this area, where are the couple of opportunities you deploy it against? Amy, I'll start with you. We'll come this way.
Well, I'm just realizing how far behind our counseling center is in the tech area. There's actually an app that Alabama State has that where all of the students' health and programming and mental health information is available. Something along those lines would be great for our population, and maybe down the road have all the universities kind of collect our data as well, so we can read a little bit more about that.
Yep.
Yeah, I think healthcare has been ripe for disruption for a long time. Some pretty heavy agendas that you have to fight up against. But I think, again, if I had the capital, I would take this collaborative care model and the technology, the two things, the data to make me work smarter, but number two, the technology to reach the patient, okay? Because that's a huge missing link. The insurance companies, they had two major missing links over the years from the start. They didn't get provider engagement, and they missed the patient engagement. No patient trusts their insurance company, okay? But they do trust the doctor, so at least we work through the doctors to get the patient to do things. But we still didn't understand our patients enough. So if I had capital, I would take the platforms like NeuroFlow has, where a patient gets the screening, customized journals, and coaching education, and yet it's not one of those free apps that they just go out there and their Fitbit connects to. It's integrated with their doctor, with their nurse at the office, with their psychiatrist, therapist, with their cardiologist. And this is for every, not just behavioral health, cardiology, GI, pulmonology, pain. Are you talking pain management? Number one thing that employers, of course, have to deal with is musculoskeletal and pain issues. And the cost that comes up against them, especially the self-insured. If we could have a collaborative care model with a pain scale tech that also then links to the effects of pain, depression, anxiety, and then links to the musculoskeletal care manager and the behavioral health care manager working together. And hey, as a primary care doctor, I'm like just sitting back like, wow, you guys go to work. Yeah.
Okay.
So, the thing is this, that this isn't a little provocative, but it's though we have the cure to cancer, and we're not using it. We have answers. We have I was involved in some of the early work in this collaborative care model in the 1990s. Okay, I mean, when you look at the adoption in primary care and other medical settings, it's maybe 30-40% have some level of behavioral integration, treating some type of screening and some type of treatment in medical settings. About 10-15% maybe have picked up a full bore integration model. Probably fewer than that actually have a full bore collaborative care model. And you say, well, what's up with that? It makes no sense. These models work. They reduce costs. They improve provider satisfaction. What's up? And, that's a whole nother discussion. We've had webinars on that here and have to go on at length, and I will not do that now. But there are a lot of reasons why there are challenges with uptake. Again, I'm optimistic. We're seeing a lot more uptake. But if there were discretionary funds to support, similar to what Jim was saying, the models of care that are evidence-based, we're not reinventing the wheel. We're taking what we know works, and if there are ways of being able to implement and scale those models of care on a large scale, it becomes a no-brainer. And so this exists, and there are some innovative relationships between payers and providers, and the federal government is now coming on board. And for example, the state of North Carolina increased Medicaid reimbursement for collaborative care by 120% of the Medicare rate, and there's been an explosion of collaborative care in the state of North Carolina. So we see that funds can make a difference, and helping with implementation. It's that change management, it's that fear of the unknown, it's the costs. And by the way, what's so striking is that when you actually look at the cost of implementing these models of care, 70% of those costs are the leadership costs. It's people like,
I thought you were two lawyers. A lawyer.
it's the lawyers too. It's the lawyers too. But it's the physicians, it's the lawyers, it's the administrators in hospitals that are very expensive, that have to sit around and talk about it and mull it over. And I don't mean to minimize that. It was my life for a long time. But it's very expensive. 20% is the operationalizing of the actual models themselves. So it's helping to manage the activation energy, delivering that activation energy to move this forward. And the reality is dollars are needed. The federal government, as I said, there's now bipartisan legislation. There are a number of philanthropists who are moving in this area, but that's where I think it's utilizing what we know. And it's a combination of these models of care and technology that I think are really the answer here.
Thank you.